organizers for giving me this opportunity to present this topic. We already discussed that immunotherapy is the backbone of first-line treatment of patients without driver mutations. And here I'll be highlighting on the role of immunotherapy in the first-line treatment of PDL1 negative, driver mutation negative, non-small cell lung cancer. So we all know that all the landmark trials of immunotherapeutic agents in the second setting has established PDL1 as an important predictive biomarker, be it nivolumab, pembrolizumab, or atezolizumab. The magnitude of benefit was much higher in the patients with PDL1 positivity. And following that, as we have already seen the previous presentation, the monotherapy trials with immune checkpoint inhibitors included only patients with PDL1 positivity, that is more than 1%. And this was like how to treat the remaining patients who had PDL1 low, because the PDL1 expression was not very high. It was ranged from 20 to 60% in various series, and Indian studies has reported a percentage around 30%. So it was important to have an optimal strategy in this population and to make use of the immune checkpoint inhibitor. So the strategies that can be adopted are one is the combination approaches using immunotherapy, other agents or chemotherapy, and other strategies to identify new biomarkers which can predict the response to immunotherapy. So such trials which has included patients with low PDL1 include Keynote 189 trial, which was a pembrolizumab based regimen, and it included pembrolizumab 200 milligram, pemetrexed, and cisplatin or carboplatin as a platinum agent. So after four cycles, patients were put on maintenance with pembrolizumab plus pemetrexed. So this trial has recruited around 616 patients, and there were three weekly cycles, and more than around 30% of the patients had a low PDL1. So this is an important trial relevant to our discussion. So this has shown a significant improvement in the OS. The median OS was around 22 months, and against the 10.6 months in the chemotherapy arm, and PFS was also significantly longer, which is 10.6 versus 9 versus 4.9 months. And in the PDL1 negative subgroup, in the lower two diagrams are PDL1 negative subgroup. There also the statistically significant benefit was maintained in terms of PFS as well as the OS, because the median OS in this population was 17 months versus 10 months, and the median PFS was 6.2 months versus 5 months. And this trial didn't show any newer safety signals. The discontinuation rate with the pembrolizumab arm was slightly higher, that was around 20% versus the 10% of the other arm. And there was a slightly higher incidence of febrile neutropenia, and 3 patients in the pembrolizumab had pneumonitis related death. So this has established the role of immune checkpoint inhibitors in combination with pemetrexed and platinum in PDL1 negative subgroup. And other trial which has recruited patients without PDL1 expression are atezolizumab based regimens like Empower 150, where the atezolizumab was combined with bevacizumab, paclitaxel, and carboplatin, which is the first arm. And there were other 2 arms, which is bevacizumab, paclitaxel, carboplatin, and atezolizumab, paclitaxel, and carboplatin. So each arm had around 400 patients. And after 4 to 6 cycles, patients are put on maintenance with atezolizumab, bevacizumab, or both. So this had a little complicated design, and the intention to treat population had a driver mutation positive patients also. And but the original trial mainly focused on the patients with wild type phenotype. And also the original article compared the efficacy of ABCP versus BCP. ACP analysis was not initially done. And also it has used high tough gene signature as a surrogate for PDL1. And this trial also had a significant proportion of patients without PDL1 expression, that is around 50%. So these are the doses used, and in the initial publication, it was clearly seen that the benefit was maintained across all the PDL1 subtypes. And this is an update. And here also the intention to treat wild type population had a significantly higher median OS of 19.5 months versus 14.7 months with a hazard ratio of 0.8. And the second figure shows the OS data in the PDL1 negative population. Here also it was numerically longer in the PDL1 in the immunotherapy arm, that is 16.9 months versus 14.1 months, though the magnitude of benefit was lesser compared to the total population. And safety, with regard to safety, there were higher immune-related adverse events, but majority were grade 1 or grade 2. And most common adverse events were rash, hepatitis, hypothyroidism, and hyperthyroidism. And in some of the patients initially had some bleeding related complications, especially in high-risk patients where bevacizumab was used. Other than this, there was no new safety signals as per this trial. So another trial which is used atezolizumab was Empower 130, where atezolizumab was combined with carboplatin and nab-paclitaxel. And it was compared against carboplatin plus nab-paclitaxel without atezolizumab. So this trial also has shown recruited around 723 patients with wild type EGFR and ALK, and this also has shown an improvement in the entire population with the median OS of 18.6 versus 13.9 months, and PFS was also longer in the immunotherapy, 7 versus 5.5. And the PFS benefit was maintained across all PDL1 strata, whereas OS was numerically better in the PDL1 negative population, but it was not statistically significant. This has to be interpreted with the realization that 60% of patients also received subsequent immune checkpoint inhibitors in the chemotherapy. And this trial also didn't show any new safety signal. So this is another option in case of patients with low PDL1. So there are newer drugs, newer checkpoint inhibitors like sintilimab, tislelizumab, camrelizumab, etc. were tried in different trials like Orient, Rational, Camel. These drugs were used in both histologies, and it was shown that they improved the PFS in non-squamous in combination with platinum and pemetrexed, but there was no improvement in the PDL1 negative subgroup. The only trial has shown some improvement in PFS irrespective of the PDL1 status was Gemstone trial, which has used a newer drug, sugemalimab, which is an anti-PDL1 in combination with chemotherapy. So these trials mainly included patients with non-squamous histology, and in squamous histology, the landmark Keynote 407 trial has shown that immune checkpoint inhibitors can have an important role in patients with PDL1 negative tumors also. So this trial, which recruited around 559 patients, had pembrolizumab plus carboplatin plus nab-paclitaxel for 4 cycles, followed by pembrolizumab maintenance up to 31 cycles. And the comparator arm was placebo plus carboplatin plus nab-paclitaxel. So here, this immunotherapy arm had a definitely higher response rate, 63 versus 39. With the median OS of 17.2 months versus 11.6 months. PFS was also high. And with respect to the PDL1 negative population, there was also the PFS and OS was higher, with the median PFS of 15 months in the immunotherapy arm versus the median PFS of 11 months, with a hazard ratio of 0.79. And with regard to PFS also, there was a benefit with a hazard ratio of 0.67. And numerically, it was 6.3 months. Median PFS was 6.3 months, and it was 5.9 months in the chemotherapy alone now. So these were the chemo-immunotherapy combinations which can be used in PDL1 negative patients. And another approach that was tried is combining PDL1 and CTLA4 blockade. And as we know, this landmark Checkmate 227 trial had an arm with just exclusively for PDL1 negative patients, which had around 550 patients. The 3 arms used in this trial were nivolumab plus ipilimumab up to 2 years, then chemotherapy according to the histological subtype. And the third arm was nivolumab plus chemotherapy. So here also the combination arm, which is chemo-free regimen, had a higher response rate of 27 versus 21%. And the median OS was 17.2 versus 12.2 months. PFS was also higher in the combination immunotherapy arm. And in the 4-year OS update, it was 29% survival was there for the PDL1 positive, and it was 24% the PDL1 negative. In the 5-year update also, PDL1 negative patients had an OS of around 20%. So, as we all know, there was initial short-term benefit with chemotherapy, but later on the benefit of immunotherapy superseded the benefit of chemotherapy. And the discontinuation rate was higher in the Nivo-Ipi group with 18 versus 9%. And the common immunological reactions seen were related to skin and endocrine. Most of them were manageable. So this is another regime which can be used in PDL1 negative patients. And as we already mentioned, there was an initial inferior responses with the combination immunotherapy arm. So the next strategy was to add chemotherapy along with nivolumab ipilimumab combination in the form of Checkmate 9LA trial. So here nivolumab plus ipilimumab was added to 2 cycles of chemotherapy, then followed by the immunotherapy combination. And the other arm was platinum-based chemotherapy according to the histological subtype. So this trial without any patients with driver mutation had recruited around 719 patients. And it was seen that the overall survival was much higher in the immunotherapy combination now with the 15.8 months of overall survival median OS against 11.8 months in the chemotherapy arm. PFS was also superior in the immunotherapy combination arm. This combination had around 57% of serious adverse events, including frequent events included pneumonia, diarrhea, febrile neutropenia, anemia, AKI, pain, dyspnea, pneumonitis, and respiratory failure. But the fatal adverse events were only 2%. So another important concept that put forward through these trials was that whether PDL1 negativity can be a robust biomarker for choosing PDL1 CTLA combination, because the 2-year OS in this PDL1 negative was 37%, which is almost comparable to the even to the PDL1 positive, that is more than 50%, who had a 2-year OS of around 45%. So this is another strategy which can be used in PDL1 negative patients. So another way to overcome this problem is to identify newer biomarkers which can predict the response to immunotherapy. But unfortunately, though there are multiple biomarkers studied, as we have already discussed, none of them are clinically validated. But I would like to mention about one biomarker, that's tumor mutational burden. We know tumor mutational burden is defined as the total number of non-synonymous mutations per sequence coding area of tumor genome. This is yet to be considered as a robust biomarker because multiple trials has shown conflicting results. It was studied in Checkmate 026 as well as Checkmate 227 trials. But recently there was a publication in JAMA Oncology from multiple US centers, which is basically a cohort study with around 1,552 patients. So 1/3 of these patients had received first-line treatment as immunotherapy, and 1/3 had PDL1 negative population. So this has clearly shown that those patients who had a high PDL expression, they defined the high tumor mutational burden. They've defined it as more than 19 mutations per megabase. That has shown that they had a much better overall survival compared to those with low tumor mutation. So other parameters also much higher in the patients, higher mutation burden. So if we look at these patients with low PDL1, that is I've highlighted in the table. So those with less than 1% PDL1 who had a low TMB had a objective response rate of 8.7 versus those with low PDL1 but high TMB had a response rate of around 46.7, which is comparable to the other population with high PDL1. And with respect to progression-free survival, it was 2.1 months in the low TMB versus it was 10.7 months in the high TMB. And it is lesser compared to the patients with higher PDL1, but still it was much high compared to those with low TMB. With respect to overall survival, it was also numerically higher in patients with higher TMB. In those with the low PDL1, but that is not statistically significant. So, though this is a cohort study, this shows some interesting information that tumor mutational burden can be a useful parameters in identifying patients who are likely to benefit with immunotherapy, especially in the setting of a PDL1 negativity. So, to conclude, if there are no resource limitations, immunotherapy can be the backbone of treatment of first-line treatment of patients with the low PDL1 non-small cell lung cancer. So the regimens which had evidence backing are pembrolizumab plus pemetrexed plus platinum, atezolizumab plus bevacizumab paclitaxel carboplatin combination. Atezolizumab, nab-paclitaxel carboplatin is another option, but in this subgroup there is no OS benefit. And in the squamous histology, pembrolizumab, nab-paclitaxel or paclitaxel with carboplatin as per the Key 189 trial. And chemo-free regimens in the form of nivolumab plus ipilimumab is also an option, along with a combination of nivo-ipi with chemotherapy. So though we need more data, testing for TMB in this population will be really useful so that we can identify patients who are more likely to benefit with immunotherapy. Thank you. Thank you.
So I have a small question. In your experience, have you seen variable PDL1 expression from primary and metastatic lesions?
You mean whether there is different PDL expression, primary and metastatic?
So, yeah, lung primary might be showing very high PDL1 expression, and a liver lesion biopsy might be showing a low or no PDL1 expression. Have you seen this kind of heterogeneity in any of your patients?
No, practically I have not seen, because in metastatic disease we do not usually biopsy two sites, and I have not seen. But if anyone from any senior person from the audience can contribute, I have not seen such a pattern.
Okay. There is some.
Hello, ma'am. Sometimes we do a baseline biopsy. Suppose we are having a head neck cancer patient, we do biopsy. We see there's a again that patient treated and had recurrence in lung. We again do a biopsy to confirm. And sometimes patients are coming from outside, so they are having some PDL1 scoring from the head neck, and they present to us in lung with the lung mets, and we do biopsy. We see approximately same, not very much great difference. I think there will be some. We see a positivity rate. There is no much difference. There is a high positivity in metastasis side also we see a positivity rate high, but I don't aware about the data. But clinically in the OPD we see usually at both the sides there is a concordance.
Okay, thank you.
Yes, thank you.